Hello and welcome back to the channel. Today we're going to talk about the dangers of acid blocking medication, NSAIDs, non-steroidal anti-inflammatory drugs like ibuprofen, naproxen, Motrin, Advil, Aleve, Bayer, aspirin, things like that, and also why those two medications will lead to eventually using antibiotics. And the reason this presentation is coming about is because I'm medically trained as a nurse, and it sounded kind of crazy to take somebody that has acid reflux, which is the acid coming from the stomach going up in the esophagus and burning it. And well, why would you give them more acid? Because some patients were taking actually acid in the form of betaine hydrochloride and getting rid of heartburn. And it made no sense to my medical training of why acids would help that. But once I started diving in the research and trying to figure this whole thing out, I was amazed at why people were taking the dangers of all these proton pump inhibitors and H2 receptor blockers, and that information is just not out there. They might give a little blib here or blib there, but nobody really understands at a deeper level. So that really created this first presentation, is the dangers of all these blocking the medication or blocking the stomach acid. And then in the second video I'm going to do later will be all the benefits of stomach acid and why you want stomach acid, and why doctors are prescribing stomach acid for people that are supposedly have too much stomach acid. So we'll go over the rationale behind that and make it more understandable from more of a medical standpoint of view, and less from an alternative standpoint of view. So again, this information is not medical advice. This is only my review of the research and putting all the pieces together for the general public. And but actually, probably most people that are going to get into this are probably medically trained, physiologically trained. But I'm going to try to do it for a little bit for everybody, so you'll be able to get the idea no matter what your level of physiology is. This presentation is for educational purposes only. Don't use this to treat yourself, diagnose yourself, change anything you're doing. Obviously, consult your personal physician who knows your history, your background, and your whole, life story, so they can make any specific medical changes, because, I don't recommend just willy-nilly getting off any medication without direct supervision. Okay. Now, I'm going to give an overview to see if you actually, want to sit through this presentation so you'll understand what we're going to cover. First of all, acid blockers are given for reflux. So it makes sense. You have acid in the stomach, and, this acid, if it fluxes up into the esophagus or goes retrograde up towards the mouth, it's going to burn, because in the stomach, you have these barriers that keep the acid from burning you. But when it gets up into the esophagus, it will it'll burn. So it obviously makes sense, if that's burning, or there's a degree of logic to this. If that's burning you up in here, then get rid of the acid. Okay. Then why are people that are don't have acid reflux, why are they being given proton pump inhibitors or acid blockers if they're on NSAIDs like ibuprofen, naproxen, Motrin, Advil, Aleve, Bayer, aspirin, things like that? Why would they be given acid blockers? And so we're going to go into that, why that would lead to those medications as well, and why, if you're taking acid blockers plus the NSAIDs, why are you going to eventually probably end up on antibiotics? What is the mechanism, the physiological mechanism of, physiology that warrants the need for antibiotics? So we're going to talk about the dangers of taking these medications from an acid point of view, knocking the stomach acid down, and also from the point of view of, these medications are proton pump inhibitors, for example. Well, what does that actually mean? We're going to go over that. And also, if you only had proton pumps in your stomach, then you probably wouldn't have much side effects from these drugs. But because you have proton pumps all over the body, and if you shut those pumps down, you're going to have problems with the brain, the heart, the GI tract, all sorts of things. And so it'll make a lot more sense after we go over the underlying mechanism of physiology for these dangerous medications. Why is stomach acid beneficial? Now I'm going to cover that mostly in the next presentation, but a little bit here. And then why do many people take stomach acid, betaine hydrochloride, for reflux? Now, why would, if you're having over acid that's fluxing up to here, how could adding more acid, that doesn't make any sense. How could adding more acid actually cause this valve to open and cause digestion to occur? So maybe people have an under acid condition, enough acid to burn you up here, but not enough acid to open this valve and stimulate digestion. So we're going to go into that, the rationale of hypochlorhydria or low stomach acid. So that's kind of an overview of where we're headed. So I hope you can join me for the next few minutes. Okay, understanding the triad, acid blockers, anti-inflammatory, and antibiotics. Well, basically, if you take an NSAID, that's going to destroy your stomach lining. And that lining is what keeps you from burning your stomach. So when you don't have that lining in your stomach, you're going to need acid blockers to block that acid and stop that acid production. And then if you stop that acid production, you're going to have the gram-negative bad bacteria in your colon. They're going to now creep up in this non-sterile environment up into the stomach, up into the mouth, down in the lungs, and cause all sorts of infections and things like that. So that's why antibiotics will soon be prescribed. So that's really the overview of what we're going to talk about. Now let's get into the specifics and look at why this occurs. Now, before I get into talking about acid and proton pump inhibitors and all that, let's just have a basic overview of what acid is. So I'm going to make this really easy to understand. So, no matter what your background, this should be at least somewhat logical. So you've all heard of pH, potential hydrogens, what it stands for. But what it is it's, and you've heard of like battery acid will burn you or something like that, or, don't get oven cleaner. Oh, that'll burn you just as bad as the acids will. So everybody has some concept of acid base. But what does that really mean? Well, if you look up here on the left-hand side, you see this acidic solution. See all these H's that are sort of free floating? Okay, whenever you have hydrogens that are not bound to something else, they have the potential to be an acid. Okay, so the more hydrogens you have in a beaker that are floating around, not bound to something else, the lower the pH. Okay, so a pH of 1 has a bunch of hydrogens. Now, as you get to neutral or to 7, you have less hydrogens that are floating. You would have an equal number of hydrogens to these OHs. Well, the OHs, I think that's hydroxyl ion, that you chemistry majors can put a comment in the description if I'm wrong on that. But basically, the OHs, that's going to be the base. So if you have a pH of 14, you've got a tremendous amount of OHs in relation to the hydrogens. Okay, so why is that important? Well, in the stomach, you have proton pump inhibitors or proton pumps that pump the hydrogen into the stomach and make it more acidic. So when we have a proton pump inhibitor, it inhibits the pump that pumps the protons in. So if you understand that the protons relate to the pH, just to make this perfectly clear, see, this is a strong acid. This is hydrochloric acid, like in stomach acid. So see, all the hydrogens are not associated with anything. But in a weak acid, you have the hydrogens bound to the bicarbonate. So all the hydrogens are not exerting their pH. So on a basic level, if you have all the hydrogens floating around, pH of 1.5. If you have what we call buffered, or all the same number of hydrogens are attached to something else, they're buffered, so they don't exert a pH. So that's kind of how the whole thing works. You can burn yourself with an alkaline like ammonia, household bleach, oven cleaner, all those are alkaline. And then you can burn yourself with lemon juice or gastric juice, things that are more acidic. So that's kind of the overview, just enough for what we're going to talk about here. Okay, normal stomach acid. Why do we need normal stomach acid? Let's start there. Normally, the stomach acid is 1 to 3 on the pH scale, so lots of hydrogens are in there, okay? And they're there to inhibit bacteria. If you do not have normal acid in the stomach, when you swallow food that's maybe not cooked or whatever, it's going to have bacteria in it. So you need to kill off those bacteria, viruses, and all that. Decrease risk of pathogenic infections. Okay, so if you eat a lot of bacteria or viruses and you don't neutralize them with stomach acid, they have more of a chance to set up shop in your body and start growing on their own. The acid helps break down proteins. Stomach acid stimulates pancreas enzymes. So stomach acid in itself helps other things start moving or start functioning. So it's a stimulator of other physiological functions. Definitely beneficial. Increases transit time. So you slow down how fast your GI moves so that you have maybe less diarrhea, things like that, so you can absorb your nutrient, your water in your colon, and so you'll preserve that water. So there's a lot of good reasons for having stomach acid. Normal absorption of calcium, iron, and B12. That's all related to the stomach producing stomach acid. So there's a lot of beneficial effects. So you can see when you shut that down, if you shut down the production of stomach acid, just on the fact that now we're not having any stomach acid, we're going to cause a lot of problems just from a stomach acid point of view. Now, let's look at the clinical importance of low stomach acid. The duodenum and the upper jejunum were usually sterile. What does that mean? Well, here's your stomach, and the duodenum and the jejunum are your first part of your small intestines. Normally, if you're dumping this acid in there, well, actually it gets neutralized by the bicarb that's pumped in. But by having acid continually going in this direction, okay, it keeps this upper part sterile, okay? And that's needed for absorbing nutrients, because you don't want a bunch of bad bacteria in here causing inflammation in your small intestines when you're trying to absorb your nutrients. That makes no sense. Acidophilus begins mid-jejunum. So mid-jejunum or mid-small intestines down. That's when your beneficial bacteria, so your bacteria that help assimilate nutrients, they help break down cellulose and things like that. Those are your good guys. You want the good guys in your small intestines, but lower down, okay, for absorption and just to keep it healthy. Then the streptococcus I found lower down. So the coliforms, the gram negative. So anytime I say gram positive, you want the gram positives in the colon. Now I'm oversimplifying it because there's some gram positives that'll kill you, but for the most part, your gram positives are your good guys. Your gram negatives should live in your colon. Okay, those are the coliform bacteria. Like they putrefy, they cause gas, bloating, all sorts of things like E. coli is down in here. So you want sterility in the stomach all the way down to mid-jejunum. Then you want your good guys in here, your gram positives like your acidophilus bacteria. Then in your colon, you want all the sort of the bad bacteria to stay in your colon. Now, complete achlorhydria, or without chlorides or hydrochloric acid, no chlorides or hydrochloric acid in the stomach, causes fecal bacteria to ascend and occupy practically the whole of the small intestines. So if you're not constantly feeding stomach acid, and bile also. Bile does also affect this as well. That's why if you get your gallbladder out, it can affect your GI tract as well. But stomach, let's just talk about stomach acid. Stomach acid coming into here and obviously being neutralized by bicarbs, but it keeps a sterile environment and the good guys in here. But what happens is if you stop the stomach acid, these bacteria in the colon move retrograde. They start moving up your small intestines into your stomach and up into your mouth and down into your lungs. So that's the problem, is you've got an overgrowth of these gram negatives that can cause havoc on your whole system that we're going to kind of get into. Waves of acid prevent the overgrowth of fecal type of bacteria, or the bad guys, in the small intestines. So that's going to wreak havoc. Irritable bowel disease. It can cause all sorts of inflamed bowels, Crohn's, you name it. You can aggravate the GI tract by not having normal stomach acid. Okay, consequences of decreased stomach acid. Increase in pathogenic organisms above and below the stomach. So before, this was sterile. That kept the esophagus relatively sterile, the mouth relatively sterile, and then down here is sterile. But without stomach acid, these gram negatives move all the way up the small intestines into the stomach. Then you have problems. Pathogenic gram negatives, bacteria, ascend into the small intestines, the stomach, bad breath, bloating, just all sorts of nastiness. You want stomach acid in there. Gas, bloating, diarrhea, constipation. Okay, now let's block the stomach acid. Now, what's the rationale behind blocking stomach acid? Well, back in the early 80s or so, I don't know, it was before that, they started giving Tums. You have acid, you pop these Tums, and it neutralizes the acid. So it's an alkaline. You dump an alkaline in there, you neutralize it. But these people were ODing on Tums, and they were going to the hospital with alkaline diseases, okay? And so that's why they thought, well, if we stop the production of stomach acid, that makes sense. I mean, that's perfectly logical. So that's what they're going to do, because GERD, or gastroesophageal reflux disease, all they're saying is the acid here refluxes into the esophagus and causes pain. So we want to get rid of that pain. All we're doing is knocking out this pain, because that pain costs $24 billion, or at least in 2000, 25% were from drug costs. Well, if I was a drug manufacturer, I'd be looking for a drug for this too, because yeah, if you can knock out that pain and get them back to work, that's great. 15% healthcare costs for, visits to the medical doctor, for investigations to say, oh yes, you have too much stomach acid, we need to give you a stomach acid blocker. 60% of the total costs were due to productivity loss, related to absence of work. You have too much pain right here in this esophagus, so you can't go to work. So it makes sense. Make a drug that'll block the acid and then get these people back to work. 20% of the US population experiences GERD's symptoms weekly, which I thought that's pretty high, but makes sense why these drugs are just some of the top selling drugs in the United States. 30 to 40% of PPIs, or proton pump inhibitors, and I'm going to explain exactly what that means in a minute, are not effective. I'm going to show you why they're not effective, because you stop the stomach acid. Now you have these gram negative bacteria that are kind of toxic to the intestine, or the small intestines. They're growing now in the small intestines, getting up in here into the mouth. Well, you're going to have pain because of the inflammation of this whole area, because you have an overgrowth of the wrong bacteria in there. So yeah, you're going to still have pain after you take these proton pump inhibitors to knock out this problem that's causing this pain. So how does a proton pump inhibitor work? Well, so here's your stomach. In the beginning, they put antacids in there to soak up these hydrogens. Okay, well, the problem was people were overdoing it, and they were causing an alkaline system, and they were ending up in the hospital with respiratory alkalosis and metabolic alkalosis and all sorts of problems. So they said, well, why don't we, instead of soaking up these hydrogens with antacids, why don't we block acid production? That makes sense. I mean, that's perfectly logical. So they first came out with H2 receptor blockers. Now this is a parietal cell, and all you need to know is parietal cell makes acid or spits out these hydrogens into the stomach. So this H2 receptor blocker is here, I'll move the H2 receptor is up here on the cell, and if you block this receptor, it doesn't send a signal to the proton pump, which is pumping the protons or the hydrogen in the stomach. So this was a good idea. It's like, oh, that makes sense. The problem is these H2 receptors are all over the body. So when you give a drug, you don't just block this H2 receptor on the parietal cells, you block them all over the body. That's why you have all these immune reactions we're going to talk about and all sorts of other problems. Then this didn't work as well. So then they switched to a proton pump inhibitor, because this proton pump would still kick this out even though this receptor was turned off. So they got smart and they said, oh, we can block this proton pump and stop all acid, and that'll be more effective. And it was. PPIs are definitely more effective than H2 receptors blockers, and you can see why. That just physiologically makes sense why they'd be more effective. So now we're going to shut it off at the PPI. The problem is these proton pump are all over the body. And they do many beneficial things for you. So you can't just send the drug only to your stomach. It's going to go throughout your body. There are H2 receptors and proton pumps in many other organs besides the stomach. Generally, blocking these receptors throughout the body can also affect the normal gland function. So it affects your entire body. You're shutting down this beneficial physiological mechanism all over the body. So here we go. We're going to see what damage can we do to the body besides knocking out stomach acid. Out of these four, the H2 receptor is not only expressed on gastric parietal cells, or that's the cell that makes that pumps the protons into the stomach, but additionally on brain tissue, cardiac tissue, smooth muscle cells, which are in the GI tract, T cells and B cells, so the immune system, and dendritic cells. So you're going to affect, if you shut off these receptors, not only does it shut it off in the stomach, it's going to shut them off in the brain, the cardiac tissue or the heart muscle, in the stomach muscles, in the immune system. So that's why you're going to screw up these other organs. It's not a side effect of the organ. It is the effect of the, of the drug. It's the effect of the drug. H2 receptor antagonists, blockers, have an imminent effect on the immune response with an overall immune activating potential. Now think about it. What diseases, if you have these diseases, would you not maybe want to take an H2 receptor blocker, like maybe inflammatory diseases like RA, immune diseases? You might not want to take, H2 receptor blockers. Usage of H2 receptor antagonists in inflammatory bowel disease patients was reported to increase the risk of hospitalizations. Think about it. If you have irritable bowel disease or inflammatory bowel disease, you've already got a disease down there, and then you shut off the life-saving components by shutting off the H2 receptors in smooth muscle and the immune system, you're going to cause all sorts of problems with physiology. So no wonder you're going to end up in more hospitalizations, because you are disrupting normal physiology, not only in the stomach, but also wherever you have those receptors throughout the whole body. PPIs increase intragastric bacterial overgrowth. Well, what does that mean? All that means is if you don't have stomach acid here, which is sterilizes, stomach acid sterilizes, you're going to have the gram negatives say, oh, let's party up here. There's more food and nutrients up in here. So the nutrients that you think you're going to digest and the bad bacteria are going to come all the way up through your small intestines into your stomach and into your mouth, actually. And that's how they get into your lungs. And we'll see in a minute, that's going to be detrimental in the ICU. Shift from gram positive to gram negative. Yeah, the gram negatives down here, the putreforms, all the bad guys that are down here are going to come up and inhabit your whole GI tract. Nitrosating bacteria convert nitrates or nitrites into N-nitroso carcinogenic compounds. Say that 20 times. Basically, well, that's why they tell you not to eat lunch meats, because they're full of nitrates or nitrites. And so you don't want this to be happening by eating a lot of lunch meats. You're making carcinogens by doing that. Well, you get these carcinogen making bacteria to move up into here and take your nitrogens that you're breaking down and turn them into carcinogenic compounds. Oops. Long-term PPIs cause gastric inflammation. So you have the gastric inflammation because all these bacteria move in, they're not supposed to be in there, and they start inflaming your GI tract. You have pain. You may not have pain from reflux, but you have pain from over aggravation of your stomach wall. 30 to 40% still have pain. And obviously I'm putting the references in here if you want to look these up. These are great articles to read through if you want more information on it. Lung colonization leads to pneumonia. See, if you bring the bacteria that are not supposed to be passed here all the way up in here and you aspirate it down into the lungs, you're going to create pneumonia. So by taking PPIs, you increase your risk of pneumonia. That makes sense now if you understand how this all works. Okay. Now, understanding complications beyond acid suppression. So acid suppression causes its own problems. Then you have the acid suppression. Let's not look at acid suppression, but let's look at the medications and how they, on their own merits, cause problems with your body. Proton pumps are also expressed in neutrophils in your immune system and endothelial cells. Now, if you know medicine, you know every lining of almost every major organ, like the GI tract, lined with endothelial cells. The kidneys lined with endothelial cells. The skin, endothelial cells. The esophagus, endothelial. The lungs, endothelial. Any major organ, the functional part of that organ is endothelium. So if you've got proton pumps in the endothelial cells, everything in the body, you can extrapolate that probably any disease could be exacerbated by taking a PPI. That would make sense, and we'll see the research in a minute. Leading to reduced neutrophil accumulation, and you cannot mount a good response from the immune system if you are taking a PPI. PPIs were demonstrated to inhibit lysosomal enzymes with broad implication in infectious and tumor immune defense. Well, think about it. Our immune systems are meant to fight tumors because we fight cancer on a daily basis. We are meant to fight these things, and without normal proton pumps in all of these tissues, you can't effectively fight cancers. You can't effectively do a lot of things. So it only makes sense. The pathology that occurs because of taking the drug is perfectly logical. Three months of anti-ulcer therapy resulted in increase in food-specific IgE in 25% of the treated patients. Now, is that saying that the other 75% didn't have any, damage? No, that's just saying only 25% had enough of a problem to be detectable. So my point is, you can have damage from these medications and not even know it. You know what I mean? Just because they can't detect it or you don't feel pain doesn't mean that you're not having a side effect from these medications. Anti-ulcer drugs promote IgE formation towards dietary antigens in adult patients, significant for peanuts, walnuts, almonds, potatoes, tomatoes, celery, carrots, orange, wheat flour, and rye flour. Well, now, why would you want to take a drug that could potentially, give you a sensitivity to other foods? Okay. Hence, the relative risk for increase of IgE response to the food allergens after 3 months of anti-acid therapy is over tenfold. So, I don't know. I hope this message resonates with somebody out there, that you need to be careful with these medications. So here, overview of the possible side effects of acid blocking therapy. You're not just acid blocking, you're blocking the proton pumps. The proton pumps, they're in your mitochondria, they make energy. Proton pumps are everywhere. So you can see why gastric cancers, okay, we can understand that now. We don't have an immune system that can now fight those cancers. Hip fracture, without acid, we're not bringing on our calcium and other things with vitamin D. Hypomagnesium, low magnesium. Okay, you're not absorbing your magnesium. Therefore, like in my other video, which I'll put a link above here, that goes into why magnesium is absolutely critical for converting vitamin D into its active. And if you want to know exactly how vitamin D affects all of your physiology, then I'll put the link above here. Nutritional deficiencies. Obviously, you're not going to absorb calcium without stomach acid, or as well. Increased incidence of cardiovascular events. Well, your heart has an endothelium, which is, the proton pumps are shut down in that. And also, you make energy for the heart. So if you're not able to make as much energy in a compromised heart, you're going to have a lot of problems. Enteric infections, mainly Clostridium difficile diarrhea. Yeah, you have an overgrowth of the bad guys, aggravating your GI tract, causing diarrhea. Community-acquired pneumonia. Now that's pneumonia you get from your community. Just kidding. So yeah, because you stop the stomach acid, now you have overgrowth in your oral pharynx and you aspirate it down into your lungs. Yes, you're going to have problems. Acute and chronic kidney disease. Your kidneys are lined with epithelial tissue with which they need proton pumps. So all of this, and dementia. Where do you make most of your energy? From your brain, or I'm sorry, your brain requires a lot of your energy. And if you shut down proton pumps, it's going to affect your brain. Okay. So that now you can understand physiologically why this drug could cause so many side effects. Acid suppressive therapy during pregnancy and childhood asthma. Now this I found it pretty shocking. But who's going to take acid reflux drugs? Pregnant females. Why? Because the baby is pushing up into the organs and you're going to push the stomach up and you're not going to be able to close those valves in the stomach, and then you're going to get acid reflux because of the position of the baby. So then they're always put on what? PPIs. Acid suppressive medication during pregnancy increases the offspring's risk of developing asthma by 51%. Not only do you affect you, you're going to affect your offspring by taking these drugs. So be very careful. The association of prenatal exposure to acid suppressive medications and asthma is similar to the exposure to other xenobiotics. The increased risk of asthma has been shown in children born after infertility treatments, exposure to acetaminophen and antibiotics, other toxins, tobacco smoke, and polychlorinated biphenyls, things like that. So there's a lot of other things that can cause it, is my point, not just PPIs. So when you're pregnant, stay away from as much exposure to abnormal petrochemicals and things like that. Okay, now we're going to go into the critical care unit. During critical illness, the gut does not pass the acid test. Okay, during critical illness, the normal microbiota are rapidly replaced by pathogenic species. Yeah, the gram positives are replaced by the gram negatives. As a result of both physiological stress itself, yeah, you know, having a disease is stressful, and the use of antibiotics. So antibiotics, you know, kind of start this whole thing off. Fecal pH appears to be highly predictive of the outcome of critical illness. Yes, if you don't have your normal acid in the stomach and the gram negatives move up into this area, you're going to have problems. Author implies disruption of intestinal microflora from the use of antibiotics impact fecal pH and may be used as global markers to predict outcome. Yeah, they found that pH is a predictor of outcome. Why? Because when you have a low pH of the stomach, you're gonna do better in no matter what condition you're in or what disease you have. When you have acid in your stomach, now granted, if you don't have ulcers in your stomach, then the acid would burn you. But in a normal, healthy stomach, having acid's always better. Because what happens is, you know, in the ICU, you know, we used to put these NG tubes, or nasogastric tubes, NG tubes. You put it in here. God, I hated doing that. I felt so bad when I had to do that in the hospital. But anyway, so you put this NG tube down. Well, if there's a bunch of gram negatives, they're going to creep up this into the oropharynx, and then they're going to get aspirated down in the lungs. That's why, you know, when you start doing all these procedures to everybody in the hospital, they start making you more susceptible to die, is basically the idea. So increased incidence of bacteremia and mortality is increased when your pH goes up in your GI tract. Nosocomial pneumonia, or hospital-caused pneumonia in the ICU, burdens the healthcare system. Is the second most frequent hospital-acquired infection and leading cause of mortality. So the patient comes in, they don't have a lung infection. They get to the hospital, they get an NG tube. Now these critters down here in these gram negatives that are residing in here, because you're taking the proton pump inhibitors or whatever else is causing it, now they creep up into the oropharynx, they're aspirated, or the bacteria start moving down in the lungs, they start feeding, because you're laying in the hospital, so you have this pooling of your fluids in your lungs. Great breeding ground for bacteria, because people don't get up like they're told, you know, they don't use your inspirometers and all that stuff. So they're breeding ground for bacteria overgrowth. Retrograde transmission of contaminated gastric contents into the oropharynx, just what I was talking about, in the critical ill. We have shown that acidifying their feedings, let's put acid in there, effective in reducing gastric colonization and therefore helping these critically ill patients. I think that's amazing. They're starting to figure out in the hospital, hey, let's acidify their feedings, get rid of all this bacterial overgrowth, and let's move on. Okay, so do PPIs affect clinical outcomes in COVID patients? Because everybody's worried about, well, they've got, you know, COVID, so do PPIs compromise? Now let's just think about this. A proton pump that stops your protons from pumping all over your body, do you think it's going to cause, you give somebody a virus, I don't care what virus it is, do you think by shutting down these proton pumps, do you think that's going to put them more susceptible to dying? I think any disease that you have. Conclusion, patients taking PPIs, proton pump inhibitors, are at increased risk for severe clinical outcomes in COVID-19. It only makes sense. I don't need to see a bunch of research on that. I can understand that as a clinician. Here's another thing. Proton pump inhibitors lead to muscle function loss, muscle breakdown. Well, think about it. If you proton pump inhibitor, you decrease magnesium, you decrease the amount of activated vitamin D. Like I said earlier, I put the link on there. If you want to see what vitamin D really does for the body, I go into great in-depth. So, or you stop the, you create the inflammation, and then the NSAIDs poke holes in your stomach, and then you get these bacteria into your body, septic, it gets into your body, and muscle function loss, muscle breakdown. But I think it has also to do with the proton pumps affecting muscle, most likely. Okay, the overall effect of PPIs. This makes sense. PPI prescription was strongly, they didn't say weakly, they said strongly associated with all cause and cause-specific mortality. You shut down proton pumps all over the body, whether you feel it or not, it's going to slowly bring you down. You may not, the first year, you don't notice it. But after that, these people on this stuff 10 years, and then they wonder why they're just accumulating, more problems. So we understand the triad with acid blockers, inflammatory bowel disease. Now we're going to go, why do we need antibiotics? Because obviously we are now having an overgrowth of bacteria, okay? Because we don't have stomach acid. Overgrowth of bacteria, it's going to get into the bloodstream, maybe the lungs, maybe the kidneys, wherever. You're just having more susceptibility. So we're going to go over antibiotics. Antibiotics now becomes the next logical sequence of events. Non-steroidal anti-inflammatory drug. I'm sorry. We're going to go over now non-steroidal anti-inflammatory drugs. Okay. And why they're prescribed with proton pump inhibitors and gastrointestinal injury. So what I'm going to do is make this logical. So in the stomach, so here's the stomach lining. These are the cells of the stomach. Here's this mucus on top of the stomach. And the mucus secretes this stuff called bicarbonate. It's like a protective, it's like a barrier. So the acid, these protons that are pumped out in the stomach, they can't affect and destroy your mucous membranes and your stomach lining because there's this layer of bicarbonate in there. So that's normally what happens. Now, when you take an NSAID, or like ibuprofen, naproxen, Motrin, Advil, Aleve, Bayer, aspirin, when you take those drugs, they stop this mucosal layer from producing this bicarb. So now these hydrogens, these potential hydrogens, now they can get in here and erode the stomach lining, cause not only pain, but a lot of it doesn't cause pain. You can erode you can have ulcers, no pain. So that, again, you can take a NSAID and say, well, gosh, it only got rid of my hand pain. So it's doing great things, but it's getting rid of your hand pain, but at the same time, it's punching a hole in your stomach and causing bleeding out. I mean, I've had patients that, they're runners and they take, for running pain, they're triathletes, they're in great shape, but they're anemic. And well, how are they anemic? Well, it's punching an ulcer in their stomach and they're bleeding out into their stomach slowly enough to cause them to get anemic. So, but they don't feel the pain. So my point is, you can have destruction of your body without feeling any type of side effect. So these NSAIDs disrupt the lining of the GI tract, cause this acid to now aggravate the stomach lining, cause you pain. So what they do is prophylactic. They give you proton pump inhibitors with the NSAIDs because they don't want you to experience pain while this erosion is occurring. And that's mighty nice that they don't want you to experience pain while you're getting these big ulcers down there. Okay, so again, PPIs are frequently used with NSAIDs to minimize complications with NSAIDs. Yeah, minimize the pain with that. NSAIDs increase gut permeability. Gut inflammation, mucosal erosion, and ulcerations. All that's saying is when you take an NSAID, you stop this lining and then you start eroding into the stomach and causing all sorts of problems. Even low doses of NSAIDs can cause erosion ulcers in the small intestines. It's not dose dependent. When you take it, it's going to cause an ulcer, whether you feel that ulcer or not. Small bowel injury in 68 to 75% of the volunteers. Volunteer, you know those people that volunteer for the drug trials and they say, oh, I felt good afterwards. Well, that's why I don't volunteer for drug trials, because you don't know what's going to happen to you. 2 weeks of therapy of NSAIDs, small bowel injury. I don't need that. So that's why I don't volunteer for that. 60% of young healthy volunteers observed large bowel erosion. So these are young people that came into these studies with no problems, and now they've got these large erosion ulcers after 7 days of 100 milligrams of aspirin. That's not that much aspirin, folks. But again, they were putting these cameras down and seeing these ulcers because they didn't necessarily feel any of this. They probably didn't feel any of it. NSAIDs increase the rate of stroke, MI, and cardiac death. Now, remember when they said, you know, when you have gum infections, you know, the dentistry, they found, oh, if you've got the subclinical dental infections that are leaking, you know, bacteria into the blood, you know, you have higher rates of stroke, MI, and cardiac issues. You know, well, it's the same thing, whether you do it in the mouth or you have NSAIDs in the GI tract, allowing for this bacteria to now enter into the bloodstream. You do not want that. That's why it increases your rate of, or that's most likely. I mean, it could be another mechanism that we don't know about with the NSAIDs. Add PPIs to NSAIDs increases the frequency of mucosal lesions. Well, that just makes sense. You're disrupting all the normal things that protect you against pathogens entering your body. Oh my gosh, I need a break. Okay, all patients on PPIs and NSAIDs have ulcerations in the small intestine. It doesn't say some, most, all patients have ulcer. You may not feel them, but you've got them. Subclinical part of the disease is not measured in clinical practice because you don't come in complaining about pain because you don't have any pain. PPIs may contribute to Campylobacter jejuni, Salmonella enteritis, and C. difficile infections. Yeah, the good guys or the good guys are gone, the bad guys are taken over. Lowers pain threshold. Yeah, your nerve endings are more inflamed because you got all these bacteria jumping in there. Mood swings. Yeah, you're aggravated all the time because your brain is constantly bombarded with all this other gram-negative bacteria were associated with ulcer formations in the animals treated with NSAIDs. Yeah. Add gram-negative. So that's where the gram-negative broad-spectrum antibiotics come in for improvement, because you've got to knock down all these bacteria that now you've allowed to run havoc on your body. So gram-negative antibiotics for improvement. Even though antibiotic use is effective with patients on PPIs and NSAID therapy, long-term use has its own side effects, including multi-strain microbial resistance. Okay. So if you want just kind of an overview on this, you can see here, what happens with NSAIDs, they block the production of this COX, that blocks prostaglandin E2. That is what decreases a healthy membrane of your GI tract. You can look this research up here if you want to go more into it. I'm just kind of hitting the highlights if you want to see it. Okay, so most patients, 80% to 100%, have active mucosal lesions in the small bowel after 2 weeks of low-dose NSAIDs and PPIs. Again, this research, if you want to go back, look it up. Dementia, kidney disease, bone fracture, all this SIBO, small intestinal bowel overgrowth, goes up 200 to 800% by being on PPIs and NSAIDs. Infections go up to 600% go up by being on these drugs. And you can see why this makes total sense if you understand the pathology of it. So that's why these are the triad of these drugs. You get put on the NSAIDs, you're going to be put on the acid blockers so you don't feel the pain of the stomach being eaten up. And then you need antibiotics eventually because you're going to have overgrowth of all these, and then you're going to get all sorts of problems. So what kind of problems do you get from antibiotic overuse? Well, I'm not going to hit this hard because this is all over, but I just want to say in this slide that each antibiotic is different in how much it destroys your GI intestinal microflora. Basically, the broad spectrums do more damage than the more targeted. Now, back in the day, woman would go in with a UTI, they'd do a count, figure out what bacteria it was, and just give that one bacteria that only kills just that one bacteria that's growing in her bladder. But now they say that's too much trouble. So we're just going to give a broad spectrum antibiotic and kill it all. Well, that's like using napalm to just wipe it out. So there's consequences to that. But basically, what happens is in the GI tract, we want a diversity. The more diversity you have, the healthier you are. So when you have 800 to 1,000 different bacterial species, they all compete and inhibit one another. Now, and you want 700 strains, inhibit the GI tract. So inhabit the GI tract, 7,000 different strains. So you have a lot of different, GI bugs. What happens is antibiotics have a major impact on the microbiota, or the amount of bugs that are in your GI tract, but it kills your diversity. So you may go from 800 strains to 100 strains. That's the problem. So see over here, you have all these different, you have the blue ones, the yellow ones, the green ones, and the pathogenic ones, but these override these. But when you add an antibiotic, it wipes out the good guys, and the bad guys grow back usually more often, not always that way. But then you have these bad guys can have a chance to take over. Negative effects up to 2 years after treatment. 2 years, we thought it, bounced back immediately, but it doesn't. Disturbance of the metabolism, absorption of vitamins, alteration, susceptibility to infections. Yes, you're more susceptible to infections more down the road because you don't have the inhibitory mechanism of a diversity. You've wiped out your diversity. Yeah, things grow back like we thought, but you don't get the diversity back. Overgrowth of yeast and Clostridium difficile. Okay, when administering 2 different 5-day courses of Cipro, within 10 months of each other, the gut microbiota did not return to the pre-treatment state, and it did with just 1 5-day course. So the more courses you put on top of each other, the more damage you're going to do. The correlation between the risk of irritable bowel disease and the number of courses of antibiotics in childhood is disconcerting, with 7+ courses of antibiotics increasing the risk of irritable bowel disease 3-fold. Yeah, it's just more of the same. Danish study found that children with normal weight mothers who received antibiotics during their first 6 months of life had an increased risk of being overweight. That gets into the crosstalk with the microbiota in your GI tract and your mitochondria. Okay, 11 of the 96 patients who received antibiotic therapy for a UTI later developed Clostridium difficile infection, C. diff infection, within 3 weeks of the treatment. See, you're wiping out, you're doing a little bit of good, but the long range effect, you just have to be aware of it. General antibiotic exposure precautions. Both maternal and child's use of antibiotics were associated with increased risk of cow milk allergies. You're disrupting the system. Antibiotic exposure before 6 months of age or repeatedly during infancy was associated with increased body mass in later childhood. Exposure to certain antibiotic groups increases the risk of diabetes. These findings reveal that unexpected outcomes of antibiotic therapy suggest that bacterial translocation as a result of alterations in intestinal microflora may provide a link between increased antibiotic use and the increased incidence of inflammatory disorders. All these drugs kind of work together in disrupting your body metabolism. Taking PPIs were constantly associated with changes towards less healthy gut microbiome. Well, we covered that. What I thought was interesting, the effects of PPIs are more prominent than the effects of antibiotics or other commonly used drugs. Stomach acid is a major barrier for inhibiting pathogenic overgrowth bacteria. So when I start talking about in the next video about the benefits of stomach acid, yeah, it might be better to get, stomach acid than get hooked on a lot of these medications that lead to more medications and more damage. Antibiotics may trigger mitochondrial dysfunction, induce psychiatric disorders. Well, what are we saying here? Well, bacteria are in the body. They're healthy to the body. Some of them are. Now, some of those bacteria have evolved over millions of years to become what we call mitochondria, or that's the part of our body that makes all or 90% of our energy. So the mitochondria are similar to bacteria. So let's see. If I add an antibiotic that kills bacteria, may it also kill or disrupt mitochondria? Absolutely. So that's why antibiotics might make you tired, is because of this. So basically disrupts mitochondria, targeting ATP synthesis. So let's just skip through here. All we need to know is these different antibiotics disrupt mitochondria in different ways. That's all I want. It's not a blanket, one blanket. So one person could take this antibiotic and have it wipe you out. The next antibiotic might not, affect your mitochondria as much. Antibiotics alter energy supply. That's why they kill your mitochondria. Enhance behavioral disorders. Your brain needs a lot of mitochondria that are functioning. When they don't function, you're going to have behavioral disorders. Brain requires 20% of your oxygen. Thus, it's a high metabolic demanding organ. This is what I found interesting. Physicians call this antimicrobial induced mania. You go crazy because you are on these antibiotics, or anti-biomania. There's a new word for you. That's a word for the day. Anti-biomania. You take an antibiotic and you go psycho, Review time. Good, we're at the end. Oh my gosh, I'm tired. Okay, so you have stomach acid. That can cause problems if it gets refluxed up into the esophagus. So they've got a solution to that pain that's caused up here. They give you a stomach blocker medication. So that blocks the stomach acid. Blocking the stomach acid not only allows the gram negatives to go up into the small intestines and into the stomach and into the mouth and give you bad breath, bloating, diarrhea, but they can also go down in the lungs and cause lung infections and all that. So that's stopping the acid. But not only does stopping the acid cause problems that way, it also causes problems because you've got these proton pumps that are inhibited. The drug doesn't just go to your stomach and inhibit the proton pumps in your stomach. It inhibits proton pumps all over your body. So that's why we see the dementia, the maybe heart disease, all-cause mortality go up when you get on these proton pump inhibitors, because your body can't survive in that environment. Okay, or survive well. Some people can probably do it, but not all can do it. And then so why would they put you on a proton pump inhibitor if you don't have gastric reflux? Well, if they put you on an NSAID, non-steroidal anti-inflammatory drugs like ibuprofen, naproxen, Motrin, Advil, Aleve, Bayer, and aspirin, if they put you on those drugs erode your stomach lining. So the acids would then eat into your stomach lining so that you don't feel that process of those ulcers being formed, eating your stomach, so that you don't feel the pain of the acid, eating your stomach acid lining. They give you a proton pump inhibitor to inhibit the pain. The process is still going on. They just inhibit the pain. So with that pain gone, you have more bowel overgrowth. Okay. So then you're going to have a double problem of the NSAID. Now you're spilling bacteria into your bloodstream, causing all sorts of problems. But the solution to that is antibiotics. So that's why these three drugs are commonly used together. And I hope this information gives you the knowledge to go to your doctor and ask intelligent questions, because really asking intelligent questions gets you better results, or at least I believe that in the hospital. If you know what to ask, you'll get better care, period. So again, if you want to see more videos like this, like and subscribe to the channel. Again, I'm going to probably do the next one on stomach acid, maybe other ones on nutrition related items. Who knows, whatever people want. And so again, like and subscribe to the channel, and you can also hit that bell notification. So if you want to see the next video that comes out, you'll be notified about that. Again, thank you very much for all your support, and I hope this information keeps you healthier. Thank you very much.